Hello everyone. So we are gonna start the. So we are gonna do two things today. First, we are gonna do the hypothyroidism as well as we are gonna do the pharmacology of the endocrine system as well. Right. So I was waiting for people to join. I think almost all of you have joined now. Right. Okay. So remember, guys, the pharmacology of endocrine system is really important. Right. The pharmacology is really important, and right. Please play a good importance to it, right? Because the diabetic drugs, the anti-diabetic drugs, they are very important right now. So let's start. Okay, so first of all, we are going to start from diabetes mellitus, right? We are going to start the treatment of diabetes mellitus. The treatment of diabetes mellitus is very simple, right? So what is the treatment of diabetes mellitus? So it depends. Are we having so for the treatment of diabetes mellitus, we have to do good exercise, we have to do good diet, we have to do blood pressure, blood glucose monitoring as well, and then we have to see whether we are going for diabetes one or diabetes two. So for diabetes mellitus, once the treatment is very simple, we are going to give the patients insulin therapy, right? Whereas for diabetes mellitus 2, we give the patients oral agents, right? Or we can give the patients injectable as well, and we are going to go into the detail of these in a bit, right? Now, one other thing is that whenever a patient is having DKA, again, whenever a patient is having diabetic ketoacidosis, so if whenever a patient presents you with diabetic ketoacidosis, you're going to give the patients a regular insulin, right? This is very important. And we'll go into the details of insulin, but remember this thing, they're going to confuse the hell out of this thing because the 90% of the insulins that we give are subcutaneous, right? Normally we give subcutaneous insulins, right? All of the insulins are subcutaneous, but in the case of diabetic ketoacidosis, we give the patient a regular insulin, right? And this insulin is given in the IV form, right? We are going to give the patient regular insulin in case of diabetes mellitus. We do not give the patient subcutaneous insulin. They're going to mention this in the question a lot, right? They're going to mention this a lot. So after that, now let's start on the insulins, right? Let's start on the insulins. Something else. Okay. Right. So first of all, we are going to see what insulins that we can give to the patient, right? So first of all, there are some rapid acting insulins, right? So what are the rapid acting insulins? So there is a mnemonic for that there is no lag in rapid acting insulins, right? So they are going to act very fast, right? So when are we going to give? So now let's focus on the treatment of diabetes. So in treatment of diabetes, there are two main things, right? First of all, whenever you eat something, the blood glucose level is going to spike a lot, right? Whenever you are gonna eat something, the blood glucose level is gonna spike a lot. It's gonna spike in 1 hour or 2 hours. So first of all, you are gonna need one insulin in patients who are having type 1 diabetes that is controlling the blood that is gonna control the blood glucose as soon as you give the patient food, right? So first of all, you are going to give a patient very rapid acting insulin, and that insulin is given after eating, right? Or just before eating, and that are going to be rapid acting insulins. And what are those insulins? We have three insulins, right? The one end is lispro, right? So it's lispro. The second one is aspart, and the third one is glargine, right? Glulizine, right? So we are going to give these three insulins whenever a patient with diabetes mellitus comes to us, right? So whenever a patient with diabetes mellitus comes to us, we are going to give the patients three insulin after eating food, right? The number one is lispro, aspart, or glulizine. Then we have the short-acting insulins, right? So what are the functions of short-acting insulins? So the short-acting insulin is going to be so the short-acting insulin is going to be regular insulin. And why do we give the patient regular insulin? We are going to give the patient regular insulin whenever the patient is having diabetic ketoacidosis, right? So whenever a patient presents with diabetic ketoacidosis, we are going to give the patients regular acting insulin, right? Now we have the long-acting insulins. I'm gonna skip the intermediate insulin for a reason, and I'm gonna come back to the insulin the intermediate acting insulins after some time, right? So these are the detamine and glargine. These are the most important ones. Why? Now, if you look at a normal person, so for example, in case of type 1 diabetes mellitus, the pancreas are gonna get destroyed and there is gonna be no insulin, right? So patient who's having type 1 diabetes mellitus, the pancreas are gonna be completely destroyed and the patient is not gonna have any insulin. But in case of a regular person, what is gonna happen is that throughout all of the day, right? Throughout all of the day, you're gonna have some amount of insulin in the body, right? You're gonna have some amount of insulin in the body, right? This is going to be some amount of insulin, and this insulin is going to be present throughout the body, and it's going to keep the blood glucose level in a normal acceptable range. This insulin is going to be present throughout the day. Now this insulin is substituted, so we substitute this insulin with the help of datimir or glargine. So we are going to give the patient insulin datimir, or we are going to give the patient insulin glargine. This is going to provide the long daily small peak, right? So remember, what is important regarding these insulins, these insulin do not have any peak, right? What does that mean? It means that the insulin level is going to stay normal throughout the day. It's not going to cause hypoglycemia. It's very difficult to cause hypoglycemia with these insulins, right? These insulins are going to be present in your system throughout the day, and these are going to provide the replacement for the insulin. But what happens is that all of a sudden, whenever you eat something, you are going to need an insulin. You are going to need an insulin for some time to control the immediate hyperglycemia after the food, and that insulin is going to be the rapid acting insulin, right? So then you're going to give the rapid acting insulin. So this is going to be the rapid acting insulin. So it's going to be lispro, aspartame, glulisine, and it is going to control the blood glucose immediately after you give the patient something, right? This is going to be the rapid acting insulin. Now we have another insulin which is the intermediate acting, right? Now, why do we have the intermediate acting insulin? Because it's very hard to give two insulins throughout the day. Now, see, for example, whenever a patient is having diabetes for 40 or 50 years, there is going to come a time that the patient is not going to, there is going to, so for example, if a patient is having diabetes for a long amount, okay. So, the thing that is going to happen is that if a patient is going to have diabetes for a long amount of time, 50 or 60 years, the thing that is going to happen is with that patient is that that patient's pancreas are going to fail eventually, and that patient is also going to need insulin. So type 2 diabetes patients are also going to need insulin after 50 or 60 years, especially if they have bad control of diabetes. Now this thing is very important due to the fact that these patients are going to be very old, right? These patients are going to be very old, and an old patients have a lot of tremors in the hand. They have dementia. They cannot administer their own insulins, right? So someone is going to administer their insulin. So now this person who is the caretaker, they have to give three insulins to the patient every time after eating food, and one insulin at the night. So this is going to be very hard. This insulin regimen is going to be very hard for the caregiver, right? Because now this caregiver have to stay with the patient. He has to stay with his father or his mother or his wife or anyone, and that patient cannot go anywhere. So this is a very big problem. So if a patient is having this problem, how can we solve this problem for the patient, right? How can we solve this problem for the patient? So in order to solve this problem for the patient, one thing that we can do is that we can give the patient NPH, right? This is the intermediate acting insulin. So this is known as the neutral protamine hedge. And this insulin, so this insulin is gonna be very good. So you're gonna give it this only two times in the day. So you're gonna give the patients in the morning and in the evening, right? Now, this is a very flexible regimen. A regimen is known as the flexible regimen of blood glucose, right? This is a flexible regimen. Why is this flexible? Because you can give this anytime, and in this patient, this insulin is not going to cause a lot of hyperglycemia in the patient, right? But we have another regimen as well, which is known as the basal regimens, right? In that regimens, we give the patient long-acting insulin, and we combine that long-acting insulin with the short-acting or rapid-acting insulin as well, right? This is going to provide This is going to provide a better thing, but the patient is going to have increased amount of problems, right? So at your level, this thing is enough. Now the next thing that we are going to focus here is on the adverse effect of insulin, right? So the most important adverse effect of insulin is going to be hyperglycemia. This is a very, very big problem with insulin, right? So you're going to see hyperglycemia. For example, if the patient skips one meals, right, then you have to change the insulin regimen. If the patient starts exercising, if the patient goes for a walk, then you have to adjust the hyperglycemia. Second thing is that you're going to have weight gain as well, right? You're going to have weight gain as well with the help of insulin because insulin causes weight gain. The third thing is that you're going to have lipodystrophy, right? What is lipodystrophy? There is going to be fat gain, right? There is going to be full fat gain or fat loss at the base of the insulin, right? So these are the three main things that you're going to have with the insulins, right? And you should keep these things in your mind, right? Okay, we'll go through the blood receptors as well, right? Any
Dr.
questions in mind?
Dr. Moaz, can you just repeat about the basal regimen, long acting plus?
Okay, so for the basal regimen, we basically for the basal regimens we are going to give the patients. So basically, basal means, so let me tell you. So the basal insulin means the insulin that is going to go in the background, right? So basal insulin means the insulin that is going to go in the background, right? And who, who are the patients to which we give the basal insulin? So the basal insulin is given to the patients who have type 2 diabetes mellitus, right? So any patient who's having type 2 diabetes mellitus, we give that patient a basal insulin, right? And for basal insulin, we could give the patients long acting insulins, right? So basically, this is the basal regimen of the insulin, right? This is the basal regimen of the insulin. Or instead of long acting insulin, we can give the patient just NPH, right? That is it, right? This is known as the normal regimen. This won't cause this no hypoglycemia. So the benefit is that the patient is not going to get hypoglycemia with these, right? But the adverse effect is that there is going to be hyperglycemia and the the glucose control is going to be much worse than a normal patient in these patients who have these insulin patterns, right? Any questions? So did you get it?
Yes. But
Okay.
you said something in which you said we're gonna combine rapid insulin. Which one regimen it was?
Okay, so when you combine the basal insulin with the help of rapid acting insulin, right, then it is known as the intensive regimen, right? So now you're combining the basal insulin with the rapid acting insulin, and this is known as the intensive regimen. This is going to provide you the best detail. This is going to provide you with the best amount of insulin coverage, right? This is going to provide you with the best amount of glucose control, right? And we can give this in the type 1 diabetes. We usually do not give it in the type 2 diabetes. We usually give it in the type 1 diabetes mellitus, right? But this is very dangerous, right? So I had a friend, he had matched with me this year as well, right? And he was on this intensive insulin therapy. So he had he had the basal regimen, and at the same time he had a rapid acting insulin as well with every major meal. But the problem he got was whenever he was going in the college, whenever he was working, whenever he was taking any lectures, there were multiple instances every month that he fainted or he was or he was very lethargic, he was very fatigued, right? And some of us had to carry a chocolate for him or any kind of a sugar for him, right? Because he had a lot of hypoglycemia due to that. That friend of mine had type 1 diabetes mellitus, right? So for type 1 diabetes mellitus, you can give this intensive insulin therapy or you can give the basal regimen therapy, right? You can give both of these. It depends upon what do you want to give, what do you want to achieve, right? The results of basal insulin, the full intensive regimen is better, but then you are gonna get a lot of problems with these things, right? Any questions?
Okay, thank you.
Welcome. Okay, now the next question is that does insulin promote lipolysis or lipogenesis? Into insulin promotes lipogenesis, right? Insulin is a drug that is going to promote lipogenesis. That is why whenever we are not having enough insulin, right? We discussed DKA yesterday, right? We discussed the diabetic ketoacidosis, and that was the thing. Then when you are not having enough insulin, there was lipolysis, right? That led to lipolysis, and when we got lipolysis, the thing that we were having was ketoacidosis. So whenever we have a lot of lipolysis, we are going to get ketoacidosis, right? Now, this is the thing that the insulin is going to lead to. Insulin is going to cause lipolysis, it's going to cause triglyceride storage, it's going to increase the glucose storage as glycogen, it's going to increase the potassium uptake by the cells. All of these are the things that the insulin is going to go do. Now let's move. Let's see if there is one question. Still Yes, so insulin is anabolic, exactly. So it's going to build up protein, it's going to cause reduce fat loss, it's going to build up glycogen, right? It's going to reduce the fat loss. That is why whenever growth hormone is secreted, whenever a growth hormone is secreted, it causes insulin resistance because it does not want the fat buildup, right? Uh, yes, it decreases lipolysis. Now the next thing is that come with are the oral hypoglycemic agents, right? There are the oral hypoglycemic agents. And what are these oral hypoglycemic agents? The most important one, the first line one is the metformin, right? It is the metformin. So what does metformin do? Metformin is going to inhibit the mitochondrial glycerol 3-phosphate dehydrogenase, right? This is an enzyme, mitochondrial glycerol. So it's the MGPD. It's going to inhibit the mitochondrial glycerophosphate dehydrogenase. What is this going to do? This is going to do two things, right? First of all, it's going to reduce the gluconeogenesis, right? So no more glucose is going to form in the body. That is the first thing that it is going to do. The second thing that it is going to do is that it's going to decrease the absorption of glucose from the body as well. It's going to decrease the absorption of glucose, right? As a result of it, it's going to increase the peripheral insulin sensitivity as well, right? So the insulin sensitivity is going to increase as well. This is a very, very good enzyme. This is the first line drug, and it is going to do all of these things. It's the first line drug. It's the drug of choice, right? It's going to reduce the HbA1c. The thing is that it increases glycolysis. It's increase the peripheral glucose uptake. It's going to increase the insulin sensitivity. And it's what are the side effects? Now, the side effects of drugs are very important. The major side effect that it is going to cause is that it's going to lead to weight loss, right? But this weight loss is often desired, right? Now you have to see two things, and whenever you are seeing anti-diabetic drugs, you are going to do two to three things. Those two to three things are very important. The first thing that you are going to notice that whether is this drug euglycemic or hypoglycemic. What does this mean? First of all, you are going to see that whether this drug cause hypoglycemia or not, because some drugs can lead to hypoglycemia by the first, right? Some insulin drugs, some diabetes drugs are going to cause hypoglycemia, whereas are not going to cause any amount of hypoglycemia, right? And you are going to keep it in your mind which drugs are going to cause hypoglycemia. Secondly, some diabetic drugs cause higher weight gain, whereas other diabetic drugs lead to weight loss as well. Now you're going to see which drugs. Okay. Okay. Maluka, I'm gonna go over it as well, right? But just okay. Now, no, so you're gonna see which diabetic drugs causes weight loss, which causes weight gain as well. Now, metformin, the major side effect is weight loss. That is the first thing, right? The second thing is that it's gonna cause vitamin B12 deficiency. This is very important. Why? Because already we are gonna get some kind of neuropathy in diabetes. But when you're gonna get vitamin B12 deficiency, that is gonna worsen the symptoms a lot, right? You're gonna get more neuropathy. That is why whenever you're treating a patient with diabetes, we usually add vitamin B12, that is cobalamin in their diet, right? So we usually add vitamin B12 in the diet to a patient who are having diabetes, right? So keep this thing in your mind. Okay. The third thing is that it's gonna lead to lactic acidosis as well. Sometimes sometimes metformin is gonna cause lactic acidosis, right? And it causes metallic taste as well. These are the things that it is gonna do. So since it leads to lactic acidosis, you cannot give it to a patient who is having renal failure. You cannot give metformin to a patient who is having renal failure, right? But remember, it is the first line drug. So any questions to know? Yes, I will be. Yes, so when I summarize these things, then we're gonna lead to the we're gonna discuss the insulin effects. Dr. Laibo, what was your question? Do you have any question?
Yeah, I have a question from the insulin part about the NPH, but I think I'll just ask it at the end.
Okay, okay, sure. Right. Now the next drug that we're gonna study is the pioglitazone. Right. So I told you. What is pioglitazone gonna do? Right. So pioglitazone is gonna. So these belongs to the thiazolidine diones group. Right. So this is the pioglitazone. There is the rosiglitazone as well. Right. So there are two, pioglitazone and rosiglitazone. What does pioglitazone and rosiglitazone do? Pioglitazone and rosiglitazone are gonna so pioglitazone and rosiglitazone are gonna increase the activity of paroxysmal proliferator activity receptor, right? This is known as a PPAR gamma, right? So if so we discovered in cardiology there was another receptor which was the PPAR alpha, right? So that was the paroxysmal proliferator receptor alpha gene. Here we are going to look at the paroxysmal proliferator alpha receptor gene, gamma gene, right? What is it gonna do? It's gonna increase the level of some things such as the adiponectin. That is gonna increase the insulin sensitivity, right? And adiponectin is gonna increase, insulin sensitivity is gonna increase, and as a result, you're gonna get the treatment of diabetes. Why is this drug? So what's the major benefit? So every drug has some benefits, every drug has some side effects, right? So metformin, the benefits of metformin was weight loss, and it did not cause any hypoglycemia, right? Remember, metformin does not cause any hypoglycemia, so it is very good in any patient. So if you are thinking of the patient may have hypoglycemia, always think of giving metformin to that patient, right? Always start a patient on metformin if you think the patient may get hypoglycemia, right? And anyways, metformin is a first line drug as well, right? So thiazolidine diones also do not cause hypoglycemia, but thiazolidine diones are gonna lead to weight gain as well as heart failure as well as osteoporosis, right? Keep this thing in mind. This is a very tested concept, right? UVers and DNAs, USMLEs love this concept, right? That the pioglitazone, rosiglitazone, all of these are gonna cause weight gain, they're going to lead to weight gain. They're going to lead to edema. They're going to cause heart failure, and they're going to increase the risk of fractures. Right. So for example, if they give you a 45-year or 50-year-old female and that comes to you and that patient is going through a menopause and now all of a sudden this patient is having diabetes, right? You won't give the thiazolidine diagnosis to this patient. Why? Why won't you give thiazolidine diagnosis to this patient? Because this patient is already at risk of osteoporosis. That is why you are not going to give this patient. This patient is now going to get osteoporosis. Right? Now, these were the drugs. Now, the third drug were the drugs that were most commonly combined with diabetic drugs, right? So they were combined usually with metformin. But now, since Ozempic came, we have decreased their use a lot. So their uses have been decreased a lot, right? Right. So Dr. Jimmy said GI upset. That is another effect of metformin. But remember, there is a long list of drugs and a long list of side effects, right? And you do not need to go over all of them, right? They are going to get hard at some point. So first of all, remember the most important ones, right? Remember the most important side effects that are present, right? So the most important side effects are the lactic acidosis, weight loss, and the third one is vitamin B12 deficiency because these are the ones that are now, I think 50% of the drugs are going to cause GI upset, right? And if you start remembering all of those drugs, then it's going to be a major problem for you to remember all of those drugs. But what we can do is that instead of remembering those drugs, we can just remember those drugs which are at very high risk of causing GI upset, such as colchicine. So colchicine is given in the treatment of pericarditis. So this is how you are going to remember it. You're going to remember it that a person came to you and that person is having pericarditis, and we can give the patient colchicine. Now, whenever we'll give the patient colchicine, that patient will get pericarditis. Right? Keep this one in your mind. Right. If whenever a patient comes with you and that patient is being treated for pericarditis, that patient would have diarrhea. Right. And this diarrhea is due to being colchicine. Similarly, if a diabetic patient comes to you and that patient is having lactic acidosis, always you not forming in your mind, right? Similarly, if a patient on diabetes, all of a sudden is having heart failure or a fractured bone, keep thiazolidine ions in your mind, right? Now we have a third drug which is known as the sulfonylureas. So what are the sulfonylureas going to do, right? Okay. So regarding the insulin secretion, let me tell you one thing. Now, if we have insulin normally in our body, right? Uh,
Dr.
if
Sir,
this
we
is
can't hear clearly your voice.
what?
We can't hear you clearly, your voice.
Okay, wait a second. Okay, I think now you would be able to hear me more clearly. I just disconnected my AirPods, right? Okay, okay. So what I was telling you that, so first of all, let me tell you about sulfonylureas, and then we're gonna move to the colchicine part later. So if this is the cell, right? Normally, what is gonna happen is that the for so whenever a cell comes, so whenever you're gonna eat anything, right? The first thing that is gonna happen is that glucose is gonna come into the body. Glucose is gonna come into the cell. Glucose is gonna increase the ATP. Glucose is gonna increase the energy. When the ATP is gonna be increased, right? What is gonna happen is that calcium is gonna come into the cell, right? It's going to cause calcium to come into the cell. And at the same time, ATP. So now there are some other cells which are known as, now there are some other receptors which are known as the potassium receptors. So here there are going to be potassium receptors that are going to be present. So ATP is going to close these potassium channels. And when these potassium channels are going to close, the cell is going to get depolarized and that is going to release the insulin in the body, right? So this is how insulin is normally released in the body, right? That it glucose is going to come into the body. Then when the glucose is going to come into the body, it's going to close, it's going to make ATP and the ATP is going to close the potassium channels and then the insulin is going to be secreted. Now we have some drugs which are known as the sulfonylureas. What are these drugs going to do? These drugs are going to close the potassium channels, right? Cell is going to depolarize and insulin is going to be secreted, right? Now, these are going to secrete the insulin. So, they may secrete a lot of insulin if you take a lot of sulfonylureas, and that is why these are going to cause hypoglycemia, right? These are going to cause hypoglycemia and weight gain. So these are the major side effects of these drugs, right? These are very cheap. These are very low cost. So it was used all over the South Asia and Southeast Asia and all over the Asia, right? So in Asia, you in Asian populations, you are going to see that a lot of patients are being on the are being treated on the sulfonylureas. Why is that? Because these drugs are really cheap, right? These are drugs are really cheap. You can get like 1,000 tablets on them for $10, right? Whereas Ozempic and GLP-1 analogs usually cost $100 to $150 for 1 month supply. That is why, since the till D days, sulfonylureas are used a lot for treatment, right? But the most important side effect that is they are going to cause hypoglycemia, and the second thing is that they are going to lead to weight gain as well. The third thing is that they are going to cause a disulfiram like reaction, right? So whenever you take the first generation sulfonylurea such as chloropropamide or tolbutamide, which we do not give any, right? We do not give these anymore, but if we give but if we give these sulfonylureas to any patients, what is going to happen is that these patients are going to, along with alcohol, these patients are going to get a disulfiram like reaction, right? Now, what is a disulfiram like reaction? So disulfiram like reaction usually means that, mm, so basically, whenever you take alcohol, right, and you take any kind of a drug that leads to disulfiram like reaction, that alcohol is not going to get digested, right? That alcohol is not going to get cleared from the body. And when that alcohol is not going to get cleared from the body, you are going to get flushing, tachycardia, and hypertension due to that alcohol. You're going to get flushing, you're going to get tachycardia, you're going to get hypertension as well. So all of these things are going to happen when you are going to take, whenever you are not going to give first generation sulfonylureas the along with alcohol, right? So keep this thing in your mind. So remember, whenever a patient is being treated for diabetes, right? And so, for example, if they give you a patient that a patient comes from you from a third world country, because sulfonylureas are being commonly used in third world country for diabetes, and now this patient gets a disulfiram like reaction, or this patient gets flushing tachycardia, and at the night the patient was at a party, then the thing that should come into your mind is a disulfiram reaction due to sulfonylureas, right? Now we are gonna go to the most important drugs, which are the GLP-1 analogs, right? Okay, so can you explain about the edema also? Okay, so okay, so the edema osteoporosis. Okay, so basically, whenever you are taking pioglitazone or rosiglitazone, so if you are giving the patients pioglitazone or rosiglitazone, these are the thiazolidine dimers, then these patients can get weight gain These patients can heart failure, these patients can have edema, and these patients can have osteoporosis. So if whenever a diabetic patient comes to you and that patient is having any of those symptoms, so usually a lot of diabetic patients have heart failure as well. So you do not give this patient thiazolidine diones, right? We do not give this patient thiazolidine diones because that can lead to a lot of worse effect in these patients, right? Now we have the most important drugs right now in the history of diabetes, right? Because they have changed the landscape of diabetes and surgeries as well, right? And these are the GLP-1 analogs, right? I've already told you what does GLP-1 does, right? So GLP-1 is a drug that is secreted whenever there is glucose in the body, right? So whenever you eat something, incretins are gonna be released, and incretins are GLP, right? They are gonna be released. They are gonna reduce the glucagon. So when the glucagon is gonna be reduced, you are gonna get better. Yeah, so it's gonna reduce the glucagon, and glucagon increases glucose, so the glucose is gonna be low. It's gonna decrease the gastric emptying, right? It's gonna decrease the gastric emptying. The last thing that is it is gonna do is that it's gonna increase the insulin release, right? It's gonna do these three things. So the insulin is gonna be increased as well. Now the side effects are, first of all, it's gonna cause weight loss, which is desired. It's gonna increase satiety as well, which is desired. So the patient's appetite is gonna be reduced. And the last thing is that the patient is gonna get pancreatitis from these. So very important side effect of these is pancreatitis. It's gonna cause pancreatitis, right? And in cats, in rats, it has caused medullary thyroid cancer. In rats, it has led to medullary thyroid cancer, right? Now, these things may seem minor, but they are important, right? So I remember back in October or November, so it was November, and I was having one interview at a place, and the interviewer was so it was basically for my residency program, and the interviewer was an attending of an endocrinology, right? And all I remember was that he tested me on all of these drugs, right? He tested me on all of these drugs, and he said that I would recommend you because I knew all of the side effects. Is it still low now? I don't think so. It's low now. Okay, so the basically the things in the side effect of these drugs are very important, right? The side effect of these drugs are very important. You should keep all of these side effects in your mind, right? All of the side effects and all of the mechanisms of action of these drugs are really important, right? So when once we complete this, we are gonna go over them again, right? So this was the GLP-1 analogs, right? These were the GLP-1. Now we have another enzymes which are the DD4 inhibitors, right? Now we have the DDP4 inhibitors. So what are the DDP4 inhibitors going to do? So DDP4 inhibitors usually, so DDP4 usually cleaves GLP-1. It destroys GLP-1. So what are DDP4 inhibitors going to do? So DDP4 inhibitors are going to deactivate DDP4, as a result of which GLP-1 are going to increase, right? And then it's going to do the exact same thing. So these are the linagliptin. So this is the linagliptin. Then there is saxagliptin, and there is sitagliptin, right? So these are the gliptins, right? So remember, whenever you're doing drugs, remember the drugs with the last name, right? So the gliptins, right? So whenever you see leptin in anything, so saxagliptin, linagliptin, then you are gonna know this is a DDP4 inhibitor. Similarly, in case of whenever a drug ends in tide, right? So whenever any drugs end in the tide, so exenatide, liraglutide, semaglutide, then these drugs are GLP-1 analogs, right? Now, uh, okay, and if any drugs end in ide, right? Then it's usually is gonna be sulfonylureas, right? So chlorpropamide, tolbutamide, glipizide, glyburide, repaglinide, netiglinide, right? So all of these ends in ide. So all of these drugs are gonna be sulfonylureas, right? So usually we name the drugs by giving them a common last name. So the common last letters, right? So keep these things in your mind, right? So if it's ending leptin, right? If it ends in leptin, yes, then it's gonna be DDP4 inhibitors. If it ends in tide, then these are gonna be GLP-1 analogs. If it's end in ide, right, then it's gonna be sulfonylureas, right? If it ends in zone, right, so rosiglitazone, pioglitazone, then these are all gonna be thiazolidine diones, right? So These are, and this is how you're gonna remember these drugs, right? Now we have the SGLT2 inhibitors. So remember, two drugs improve the cardiovascular mortality in case of diabetes. One are the GLP-1 analogs, and the other are the SGLT2 analogs, right? So the other are the SGLT2 analogs. Now, SGLT2 analogs, yes,
Sorry.
Sir, I had just one question.
yes,
Sir, like the two drugs that you described now, the one are the GLP-1 analogs and the other are the DPP-4 inhibitors. Like their
yes.
mechanism of action is completely different because one is an analog and the other is one is actually inactivating the GLP-1. So how is their action the same? Because they are doing
No.
the same thing.
Okay. So so basically GLP-1, so this is the GLP-1, right? And GLP-1 is destroyed by DDP-4. So DDP-4 is a thing that is going to destroy GLP-1 in the body, right? And the thing that we are going to give sitagliptin is going to stop DDP-4, right? So sitagliptin is a friend of GLP-1, right? It's going to stop the DDP-4. And when it's going to stop the DDP-4, the GLP-1 is going to increase, right?
Okay, okay.
Okay. So it's gonna decrease, it's gonna inhibit the DDP-4, and then the GLP-1 is gonna increase, right? Any other question? Okay.
I have the same question, but I still don't get the mechanism of how the GTPT4 G
Okay.
DBT4 inhibitor.
Okay. So basically, see, this is the GLP-1. The GLP. So if this is the body, there are 10 molecules of GLP-1. So this is GLP-1. This is GLP-1. A lot of GLP-1 are present, right? So what is going to happen is that the DDP-4 is going to come. So the DDP-4 is going to come here, and this is going to kill GLP-1, and the GLP-1 levels are going to get low, right? So now we discovered an enzyme, now we discovered a hormone, now we discovered a medicine that is going to destroy DDP-4, right? So when the DDP-4 is going to get destroyed, there won't be anything that is left behind, right? So nothing will be left behind, and when nothing will be left behind, the GLP-1 are going to be increased, right?
Oh,
The GLP-1 are going to be increased. That is how it's going to work. Now
thank
we have the SGLT2 inhibitors, right? So what are the SGLT2 inhibitors? So the SGLT2 inhibitors are drug. And so if we have they have this, so if this is the so if this is the nephron, we have this drug here, right? So this is the nephron like this. This is the proximal convoluted tubule, right? And a lot of glucose is going to go into the proximal convoluted tubule, right? And here there are SGLT2. There is a channel which is known as a sodium glucose co-transporter, right? This sodium glucose co-transporter is going to absorb the glucose, right? It's going to absorb the glucose, so the glucose in the body does not get lost in the urine, right? It's going to close the glucose in the urine to stop. Now what is going to happen is that we are going to give an inhibitor, the SGLT2 inhibitor, that is going to block this channel. So these drugs are in the flosin. So these are the canagliflozin, these are the dapagliflozin, these are the empagliflozin, right? So these are gonna decrease the absorption of sodium and glucose. As a result, all of the sodium is gonna go into the water and go into the urine, as well as water is gonna follow it, as well as glucose is gonna go with it as well. So it's gonna cause natriuresis, it's gonna cause diuresis, right? And it's gonna cause glucosuria as well. So glucose is gonna go into the urine, and the glucose levels are gonna be reduced. Now, whenever you are gonna have glucose in the urine, the microbes, the bacteria and the fungi are going to come there, and they're going to have a party on this urine, right? And when they're going to have a party on this urine, you're going to get UTIs, right? You're going to get UTIs, and again these are going to cause weight loss because all of the glucose are going to be reduced. And again, these drugs improve cardiovascular mortality and cardiovascular outcomes as well, right? They are going to cause dehydration. They are going to cause UTIs. The glucose is going to be gonna go all in the water, right? And this is going to cause a lot of side effects, right? So remember the side effects of these. They are going to cause all of these side effects. Now let's finish. Now let's move to the thyroid drugs, right? So first of all, we have a simple drug which is known as the levothyroxine. I think all of you know about the levothyroxine. So basically, this is the hormone replacement or T4, right? This is the replacement for T4, and the replacement for T4 is the leothyronine, right? And we usually give levothyroxine, right? And when do we give the patient levothyroxine? Whenever the patient is having any kind of hypothyroidism, right? Whenever the patient is having hypothyroidism, we are going to give the patient levothyroxine, right? Now, the next drugs that are important are the thionamides, right? So, what are the thionamides? So, thionamides are the drug that we use in the treatment of hyperthyroidism, right? How do these drugs work? So, we have the two drugs. One is known as the PTU, which is the propylthiouracil, and the other one is the methimazole, right? So, we have the propylthiouracil and we have the methimazole as well. So, what are these drugs gonna do? So, these drugs are gonna block thyroid peroxidase, right? These drugs are going to block thyroid peroxidase. What does thyroid peroxidase do? Thyroid peroxidase oxidizes iodine. So the iodine that is present in the body. So remember I told you on the first day of the physiology that iodine is going to get oxidized to iodide. This won't let this happen. And once there won't be any iodide in the body, right? Then thyroid hormones are not going to be produced. So as a result, there won't be any synthesis of thyroid hormone, right? Now, one other thing regarding PTU is that PTU or the propylthiouracil blocks 5' deiodinase as well. So it's gonna block the 5' deiodinase as well. And then when this is gonna get blocked, T4 won't be converted into T3, right? So PTU works on a dual pathway and the methimazole works on a single pathway, right? We usually use it in hyperthyroidism, right? We usually use this for the treatment of hyperthyroidism, right? Now, one other thing is that you cannot use this in the treatment of Graves' ophthalmopathy as well, right? So, if a person is having hyperthyroidism and is having Graves' disease, and the Graves' disease is leading to eye problems, then we cannot use this thing, right? Then we cannot use these things. Now, what are the side effects? The most important side effects that you would love to question the NBMEs, the USMLEs, love this question is that whenever you give the patient thionamides, these patients can get agranulocytosis. What does that mean? That means that the patient is going to have less amount of neutrophils in the body. The WBCs are going to be decreased. So they're going to give you a question that a patient was suffering for hyperthyroidism and we start the patient on treatment with propylthiouracil. And all of a sudden the patient is having sore throat. And they are going to give you the CBCs as well. And a lot of students are going to ignore the CBC. And when you are going to look at the CBCs, you are going to see that the patient is having no neutrophils and no WBCs in the body, right? Then this is going to be agranulocytosis. And then they're going to ask you what is the most likely cause of this agranulocytosis. So the most likely cause of this agranulocytosis is going to be thionamide or propylthiouracil or methimazole induced agranulocytosis, right? Now, one more thing that is important is that propylthiouracil causes hepatitis, right? PTU leads to hepatitis. PTU leads to hepatitis. Whereas so BTU is causing hepatitis, whereas the methimazole is a teratozole. And why is this thing important? Why are these things important? Now, this thing is important due to the fact that PTU is used in the first trimester. P stands for P, right? P is PTU and P is primary, and primary means first. So PTU is used in the first trimester, and it is used in the first trimester to treat hyperthyroidism of pregnancy. If there is any hyperthyroidism of pregnancy, we are going to use PTU. Why don't we use methimazole in the first trimester? Because methimazole causes aplasia cutis, right? Aplasia cutis, right? And then as soon as the first trimester ends, we are going to shift the patient to methimazole, right? Why do we shift the patient to methimazole? Because propylthiouracil usually causes hepatitis. It causes life-threatening hepatitis, and that is why we do not use it normally. Normally, we are going to use methimazole. The only place when we use propylthiouracil is during the first trimester of the pregnancy, right? But methimazole causes aplasia cutis. That is why we do not use propylthiouracil during the first trimester of the pregnancy, right? So liothyronine. So the side effects of liothyronine are going to be the same as that of hyperthyroidism, right? Tachycardia, heat intolerance, tremors, arrhythmias, atrial fibrillation, myopathy, right? Uh, Increased reflexes of the body. All of these things are going to be present with these. Now, these are the some drugs. So now there are some drugs like this, and these are very important. So we have already covered when do we use GH. So we are going to use GH in GH deficiency and Turner syndrome, right? Now, conivaptan and tolvaptan are ADH antagonists. So they are going to work against ADH, and when we use them when we have SIADH, right? So whenever we have more ADH, we are going to use conivaptan and tolvaptan. But the important thing regarding these are these act on V2 receptor, right? They won't act on the V1 receptors. Now, we can use the macrocycline as well. It is an ADH antagonist as well. What is different here is that this is a tetracycline, right? This is a tetracycline, and it's gonna act both on the V1 and V2 as well. And desmopressin is an ADH analog, and we have discovered in detail about where desmopressin acts, right? So now desmopressin is a very high yield drug. Why is that? First of all, desmopressin is used for diabetes insipidus. Whenever a patient is having central diabetes insipidus, we have discussed earlier that how desmopressin is going to treat that, right? Similarly, in case of sleep enuresis, so whenever a patient is having urination while the patient is sleeping, we give the patient desmopressin. Why? Because desmopressin is going to increase the absorption of water, and then when the absorption of water is going to increase, the patient is not going to have any more sleep enuresis, right? Now, two other things where desmopressin can be used is the von Willebrand disease and the hemophilia. Why? Because desmopressin causes increased release of factor 8 and von Willebrand factor. Right. So when we were gonna have VVF, VWF, and so we're gonna go into the detail of this in the in the oncology portion or the hematology portion in very much detail, right? So we have already covered octreotide. So how it's gonna use in the acromegaly, carcinoid, gastrinoma, glucogonoma, and esophageal varices, and oxytocin. So oxytocin is used in two places, right? So remember that oxytocin is a drug that encloses so you can skip this for now as well. Why? Because we are going to cover it in the reproductive portion in detail, right? But for now, just remember that oxytocin causes induction of labor. It's going to cause the uterus to contract. We are going to go into the detail of how it causes the uterus to contract and why is it important here, right? And when the uterus contracts, the vessels inside. So if this is the uterus, the vessels that are present inside the uterus are going to contract as well. And if there is any hemorrhage in the uterus, that is going to get controlled. Now, fludrocortisone is a very simple drug. It's an analog of aldosterone, right? It's an analog of aldosterone. It's gonna cause all the functions of aldosterone, and we use it in primary adrenal insufficiency, right? We do not use fludrocortisone in secondary and tertiary adrenal insufficiency. Why? Why don't we use fludrocortisone in secondary and tertiary adrenal insufficiency? Anyone? Why don't we use fludrocortisone in secondary and tertiary adrenal insufficiency?
Because in
Because in
primary,
secondary and tertiary,
there is a gland problem in primary adrenal insufficiency.
Anyone else?
because secondary tertiary, it involves the pituitary hypothalamus or it's related to treatment. But here we need aldosterone analog.
Okay. Anyone else?
I think in the secondary we don't have deficiency of aldosterone, while in the primary we have. So maybe that's why.
Yes. So in secondary and tertiary adrenal insufficiency, there is no aldosterone deficiency, right? So there is no aldosterone deficiency in secondary and tertiary. We discovered it in detail yesterday, right? That in secondary and tertiary adrenal insufficiency, only cortisol is deficient, right? And we understand the mechanism of it as well. Why? Because in secondary and tertiary adrenal insufficiency, only ACTH is problematic. And when ACTH is problematic, we are not going to get any amount of cortisol, but we are going to get aldosterone. Why? Because aldosterone is usually secreted with the help of RAS. It's going to secrete it with the help of renin-angiotensin system. It does not need ACTH. That is why we are not going to need fludrocortisone in secondary and tertiary adrenal insufficiency, right? Keep this in mind. This is a very important difference. In secondary and tertiary adrenal insufficiency, cortisol levels are normal, right? In secondary and tertiary adrenal insufficiency, cortisol levels are normal. So we do not need any amount of uh, aldosterone in secondary and tertiary adrenal insufficiency. Right? Okay. Now we have a drug which is known as the Savilamar, right? So Savilamar is very easy, right? So what does Savilamar does? Savilamar is gonna bind the phosphate, right? Savilamar is gonna bind the phosphate in the GI tract, and when the phosphate is binded in the GI tract, what is gonna happen is that you're gonna so cevilemer just binds the phosphate that is present in the GI tract, and that phosphate is not gonna get absorbed, right? And we went into the detail of parathyroid hormone, right? That whenever parathyroid hormone is high, it's gonna thrash the phosphate. There is gonna be hypophosphatemia. But whenever a patient is having CKD, right? Whenever a patient is having CKD or chronic kidney disease, the phosphate is not gonna get secreted in the from the body, and there is going to be hyperphosphatemia, and hyperphosphatemia is going to form chalk all over in the body. So in order to remove all the phosphate from the body, we are going to give the patient Savilamar, right? So if they give you a question that a person comes to you and that person is having diabetes, and as a result of this diabetes, this patient had diabetic nephropathy, and now this patient's kidney is at last stage, right? So he has CKD of stage 4, and they give you labs and the phosphate is increased a lot, and then they give you a drug and they say this drug is given to reduce the chalk formation in the body, and then they're going to ask you what is the mechanism of this drug. So the mechanism of this drug is going to be that this is going to be a non-absorbable phosphate binder that is going to bind the phosphate in the GI tract, right? Similarly, in the same way, we have cation exchange resins as well. So what are these cation exchange resins? These cation exchange resin are the petalumer, the sodium polystyrene sulfonate, and zirconium cyclosilicate. They are going to bind potassium in the colon, right? And the potassium is going to be excreted in the feces. And we use this whenever we have hyperkalemia, right? Now we are going to go into the hyperkalemia, hypokalemia, hypophosphatemia, hypernatremia, hyponatremia in a lot more detail in the renal portion, right? So we are going to start renal tomorrow, and in renal we are going to go into the detail of these portions, right? And these things are very important. But the treatment, you want to see the treatment here, right? That the cation exchange resin, how do these cation exchange resins work and how do they function, right? Now, I need to summarize all of the diabetes mellitus treatment therapies, right? Any question?
Yeah,
Sir,
I
could
will.
you repeat the NPH, the intermediate
Uh,
acting insulin?
yes. What about that?
Oh no, I just didn't understand how is it intermediate and how does it work?
Okay. Okay. So it's very simple, right? So we have three kinds of, so basically, we have different durations of the insulin injection, right? Some insulins are only gonna act for, some insulins are only gonna act for like, so first of all, let's start from the basic insulin again, right? So we have, so first of all, we have three insulins, which are the rapid acting insulins. These are the Lispro, Aspart, and Glulisine, right? Whenever you give these insulins are gonna work within 5 to 15 minutes, right? They're gonna start working after 5 to 15 minutes. So within 15 minutes, you're gonna have the symptoms of hyperglycemia gonna go away, right? So for example, if a patient is taking, oh yes, sorry. So by tomorrow I meant Monday, right? So you obviously tomorrow is gonna be a catch up, right? And there's so everything else is gonna start from Monday, right? Okay. So yes, so I was telling you that we have insulin, glulisine, Lespro, and Aspart. These drugs are gonna act so okay. So for drug names, I think two important things that you can do is that Anki helps a lot, right? I can share my Anki guide with you guys regarding the drugs, right? So you can do the drugs from Anki, right? Second thing is that Sketchy is very good as well, right? Sketchy is very good as well, right? You can go the hard drugs, right? So you can do the antibiotics or the anti-diabetic or the high yield drugs from Sketchy as well, right? So Sketchy pharmacology is good for it as well.
Dr. Moaz, Katie is better or Pixarize? Hello?
Yes,
I wanted to ask you, Sketchy is better for pharma or Pixarize?
uh, personally, I liked Sketchy, right? But some people loved Pixarize as well, right? I never did like Pixarize, but because the details in Pixarize were a little less, and Sketchy mentioned all of the pharmacology and the mechanisms of action and side effects in a much more detail, right? So I went to Sketchy, right? And the second thing was that I used Anking deck a lot, right? For step one, I used Anking deck a lot, and Anking had at that time, so I think it was Anking V10, so ranking V10 and all of the photos of sketches, right? For pharmacology. So it was very easy for me to revise pharmacology from ranking, right? Because it had all the photos of ranking, sketchy. Now I don't know that if they have incorporated the pixelized photos as well. I think they might have in the V12 deck, right? Since there was the release of Anking Hub. But I don't know for now, right? But I really liked sketchy. It was long, but the drugs were covered in a much more detail, right? So let me tell you one thing. So when I had my step exam, so during my dedicated during the last 1.5 month, I was revising things, like I was revising all of the subjects, right? And since I had did sketchy, all of the sketchy for pharmacology, my pharmacology became so good as compared to the other systems that I did not revise it for my step exams. Right? I did not revise it for my step one in the end. I did not revise it in the dedicated. So I gave my step one at the end of third year, right? So the only pharmacology I had done was the pharmacology in the tests, right? So that was all the pharma that I did. So I did not revise it once from the first year. So I never read pharma from the first year, right? And even in the step two, I did not revise any of the pharma, and even in the step three, I did not. But the sketchy helped me a lot, right? So I think it comes down, right, but sometimes it comes down to the fact that how good of a thing you have done it in the first time, right? uh it's very easy to just remember a few things, right? So you can just do some high yield notes regarding a lot of things, right? You can just do, this is the high yield fact, this is the high yield fact, this is the high yield fact, but that's not going to help you in the long run, right? Because at any point in your USMLE journey, right? And when I first talked to Dr. Ahmed and Dr. Hamza, they told me one thing. So I asked them, why have you named this thing as the marathon? Why is this thing called the USMLE marathon, right? And they told me that because of the simple fact that this USMLE journey is not a race, right? It's not a 100-meter or a 200-meter sprint. It's a very slow journey, right? It's a marathon, right? And you need a lot of people in it with you, right? So for example, if you're just gonna walk, if you're just gonna run 1 minute or 1.5 minutes, you can do it alone. You can do that run alone. But what if I say to you that you are going on a journey to the top of Mount Everest, right? So just think of USMLE as a journey to the top of Mount Everest, right? And believe me that no climber has ever gone to the top of the Everest alone, right? They always travel in groups, right? There are always a lot of groups. They are always present with a lot of Sherpas as well, right? So these are the Nepali mountaineers that are excellent at climbing the Mount Everest, right? They have seen the path a lot of times. They have seen that path. So if someone is from Nepal, they can share that experience as well, right? So Sherpas are present, and they are excellent mountaineers. They have grown through the Mount Everest a thousand of times, right? They know where each and every crevice is present, right? Where each and every ditch is present, right? Where the ice is thin, where is the ice thick, right? What is the best part to go, right? So that is why USMLE is a long journey, right? So if you invest your time in it, right? If you invest your energy in it, it's gonna be very easy and it's gonna be very rewarding for you, right? Maybe some fact is not rewarding for you right now, right? So I remember when I was learning all the side effects of GLP-1 analogs such as medullary thyroid cancer and all of those things, right? They never came in the exam, right? They never came in a lot of places, right? So one may think that they are useless, but uh, in that interview, right, and that interviewer asked me. Yes, yes. So the things that are left behind, such as the hypothyroid and the 21 alpha hydroxylase and 11 beta hydroxylase deficiency, I'm gonna send you a video of those things, right? So I'm gonna record these things, or what I can do is that I can come in the for lecture tomorrow, right? So the follow up, So the catch up lecture, I think it's called the catch up lecture yet. So the catch up day on tomorrow, and I'm gonna take some time from Dr. Ahmed. So I'm gonna borrow some time from him, and then I'm gonna do these things with you, right? So the thing was, what I was saying is that sometime, somewhere, the thing is gonna ask to you, right? So keep this thing in your mind, right? So that is why these drugs, these things become important. And believe me, everything that you're investing your time on is very useful to you, right? Nothing is going to get to waste, right? Every fact that we are studying here, it's going to help you, right? It's going to help you in your exam, right? When you're going to be sitting in your exam, you're just going to say that Dr. Maheen said that, or Dr. Moss said that, and this thing came, and this thing came, and that thing came. So keep this thing in your mind. Okay, so regarding the insulins, so first of all, I was telling you that insulin, glulisine, aspart, and lispro, they're going to act only, they're going to start acting fast, right? They're going to act for like 5 to 15 minutes, and they're going to act for like 4 hours, right? So we are going to give this after eat, right? Yes, I'm going to share that as well with you, the antiarrhythmics, right? So now we usually combine with the long acting insulin. Now, what is NPH? NPH is an insulin that is going to start working within 1 to 2 hours, right? And it has a peak as well. So it's going to get a peak within 6 to 10 hours. So why is this thing important? This thing is important because if you give it in the morning, after 6 to 10 hours, it's going to have a peak, and after 12 hours, it's going to decline the duration. And then at the night, you can give another amount of insulin. So this is an intermediate acting insulin. So you when once you can give it in the morning, and at the end you can give it in the night, right? But the insulin glargine, datamine, and those insulin glargine and datamine, they are going to act for 20 hours, right? So you cannot combine and combine and combine and combine it with these, right? So they're gonna get very devastating side effects. Sometimes they last for even 36 hours, right? So it's hard to give these things, right? So that is why we use NPH, right? Where we use NPH for the easier therapy, right? NPH is very easy to use. But if that does not control the symptoms, then we are gonna go to the intensive insulin regimen therapy, right? Any other question?
Yes, Dr. Mars, I had the question of insulin actions, and then you said something about potassium release when glucose enters the cell. If you can repeat that, and GLUT receptors.
Okay. So first thing is that whenever insulin goes in the body, insulin is gonna do a lot of things, right? So the first thing that insulin is gonna do is that, so there are GLUT receptors. So what are the GLUT receptors? So GLUT receptors are the receptors that are gonna let. So basically, remember, there are some things that. So this is a very simple concept, and the concept was there are three types of diffusion, right? So there are three kinds of transport. I think uh, one is the simple diffusion or the simple transport, right? Simple diffusion means that anything can enter the cell without the help of anything, right? You do not need any kind of thing. Do not need any kind of help for a thing to enter. So oxygen and water enters this way, right? So oxygen enters by so water enters by osmosis, and oxygen enters by that. Now, some things you need active transport for, right? So, for example, if you look at the sodium potassium, they're gonna need the active transport pump, right? They're gonna need the sodium potassium transporter. And similarly, some things need some receptors to go for, right? And this is known as the facilitated diffusion, right? So glucose needs these receptors, right? And these receptors are known as the GLUT receptors, right? These receptors are known as the GLUT receptors, right? So you need these GLUT receptors in order for the glucose to pass through, right? They are the group of receptors, right? Now we have different GLUT receptors. What are those GLUT receptors, right? So first of all, we have the GLUT1 receptors, right? Almost all of the cells of our body had have GLUT1 receptors. What are those cells? These cells are the RBCs, they are the CNS cells, they are the cornea, they are the placenta, the fetal tissues. They do not need any amount of insulin. Okay, so normally GLUT receptors are going to let the glucose parts, right? Now, some GLUT receptors are going to need insulin for them to function, right? So, GLUT1 receptors do not need insulin, right? They're going to let glucose parts at any time. You're not going to need any insulin for them. But then we come on to the GLUT2 receptors. The GLUT2 receptors again are not going to need any insulin, right? They are present usually in the liver and in the pancreas. They are present in two places. They are present in the liver, they are present in the pancreas, and the main thing that they do is they are going to act as glucose sensors, right? They are going to act as glucose sensor in the liver, and they're going to act as glucose sensor in the pancreas. And when they go, so now comes your potassium thing, right? Now when the glut2 receptors allow the glucose to go into the pancreas, it's going to get oxidated, right? It's going to get converted into ATP, and that ATP is gonna close the potassium channels inside the cell. And as soon as the potassium channels close, a lot of potassium is gonna be present inside the cell, and that is gonna cause depolarization of the cell, and that is gonna release insulin. Right now, where does this insulin comes into play? This insulin is gonna go to the muscles and heart muscles, skeletal muscles, and the adipose tissue, and then then this insulin is gonna open the glut4 receptors there, right? When the glut4 receptors are going to open, all of the glucose is going to come into those cells, and when the glucose is going to go there, the glucose in the blood is going to be decreased, right? This is why these cells are important, right? Now only glut4 has need for insulin. This is the mnemonic that I had, right? So, so glut4 has need for insulin, so we write 4 in this. So 4 and 4. So GLUT4 has need for insulin, right? And then there's GLUT5. GLUT5 transports fructose, right? And we usually need it in the sperms, right? They're usually present in the sperms because sperms has fructose, right? Sperms has fructose, semen has fructose, and sperm use fructose as the main amount of energy, right? So these are the glut receptors, right? Now we have two other receptors for insulin as well. What are these receptors? These are the SGLT receptors, right? These are the co-transporters. They transport sodium and glucose at the same time, right? They're gonna transport sodium and glucose at the same time. And SGLT2 receptors are the most important receptors. Why? Because they are going to absorb 98% of the urinary glucose. So 98% of the glucose that is present in the tubules that go into the urine is going to be absorbed by SGLT2 receptors, right? One molecule of glucose is going to absorb with one molecule of sodium, right? But we have an enzyme, we have a medicine that is known as the SGLT2 inhibitors, and these SGLT2 inhibitors are going to block the absorption of sodium and glucose, and that is why we are going to get the hypoglycemia. Then we are going to get the beneficial mechanism of action of these drugs, right? Now we have another drug which is known as the SGLT1. We have another receptor which is known as the SGLT1. So what does the SGLT1 do? So basically SGLT1 does another thing as well. SGLT1 is going to absorb the sodium into the body from the gut, right? And when it comes into the blood, it's then going to go to the pancreas and to the hepatocytes, and there then it's going to be GLUT2 receptors, and the GLUT2 receptors are going to get the glucose in, then they're going to form the insulin, right? And then insulin is going to act on the GLUT4 receptors, and then the GLUT4 receptors are going to transfer the glucose to adipose tissue as well as striated muscles. And then the second function of insulin comes into being. What is the second function of insulin? Then the body is going to say, now we have insulin, we need more amount, so now we are going to store the glucose. So body is going to store all of that glucose in the form of glycogen. That is the second thing insulin is going to do. The third thing is that insulin is going to say that we have a lot of energy. Insulin is a signal marker for energy in the body. Remember this thing. Insulin is a signal marker for energy. So whenever you are going to have insulin in the body is going to think, I have a lot of energy. So now the insulin is going to say, we have a lot of energy. Now let's make some fat, right? Now the body is going to make some fat as well. That is why the insulin is going to cause lipogenesis. It's going to cause glycogenesis as well, right? It's going to cause glycogenolysis as well. It's going to form glycogen. It's going to form triglycerides. It's going to go. It's going to let all of the glucose go into the cell. So these are the functions of insulin, right? Now, Dr. Maheen is here and she's going to take the UL session. So, hello, Dr. Maheen. So, I think I'm going to go away now.
Hi guys, yeah sure, thank you Dr. Moaz. Alright, okay, let me share my screen with you guys. Alright, okay, so the first question for today is, wait, what's happening? All right. Okay. So the first question we have for today is the patient is thin, has dry skin, covered by a fine. Okay, I think we discussed this yesterday, so I'm not gonna go through this. We did discuss this. I think wait. Until where did we stop? I think it was question 10. Yeah, so it's 11. All right. Okay. However, glycemic control remains suboptimal due to maternal non-compliance with insulin treatment and poor adherence to dietary recommendations. Examination of the neonate is unremarkable. Which of the following is most likely primary mechanism responsible for the patient's low blood glucose concentration? So there is this 2-year-old newborn born. He has a blood glucose concentration of 30. All right, gestational diabetes treated with insulin. What is happening?
As the history is, there is mother is diabetic and the function of the pancreas be also increased during the gestation, and after birth there is no glucose, means no intake still by oral, and increase still there is increase of penicillin that causes the hypoglycemia. I think the B, hyperfunctioning pancreas.
All right. Okay, yeah. So this is a step 2 algorithm. When I said that, they have made step 1 difficult, I wasn't kidding. This is exactly step 2 algorithm. So this gets tested a lot in step 2. Now they're putting it in step 1 as well. All right. So what happens when there's maternal hyperglycemia? Usually people get confused. Oh, in a child or a newborn, they will be hypoglycemic. But I want you to remember this. All right. So initially in the second and third trimester, what's happening is that there's fetal hyperglycemia going on. All right, this what happens in the second to third trimester, whereas further in the first trimester there's neonatal when the baby is born, there is neonatal hyperglycemia going on, but in the second or third trimester it's fetal hyperglycemia. All right, so that is what I want you to remember. The other thing I want you to remember, the side effects of maternal hyperglycemia. There are congenital heart disease, neural tube defects, small left colon, spontaneous abortion. Congenital heart defects, we discussed that it causes aortoseptoventricular defects. We also discussed about neural tube defects. It can cause polycythemia, any sort of organomegaly. Also, there can be any sort of clavicle fractures, hypertrophic cardiomyopathy as well. But in terms of USMLE step 1, I want you to remember that during the second and third trimesters, the fetus can have hyperglycemia, and when the baby is born, they have neonatal hypoglycemia. All right. So if you kind of scroll, okay, what's happening? Why is my okay? So you see that there's neonatal hypoglycemia written over here. So fetus will have hyperglycemia, neonate will have hypoglycemia. All right. And if you kind of go down and see that why is it happening again, fetal hyperglycemia can cause compensatory hyperfunctioning of the pancreas because of insulin. After birth, persistently elevated insulin levels leads to transient hypoglycemia. Can anybody tell me, how does hypoglycemia present in a newborn baby? Anyone?
Seizures.
The baby
Tachycardia.
will sleep a lot,
Yeah.
drowsy or sleepy.
Seizures, yes. What else?
Poor feeding, lethargy.
Fatigue, poor feeding.
Very good. Poor feeding, seizures, all of that can be presented as hypoglycemia in a newborn baby. All right, next question. Laboratory study shows serum glucose of 72. There are positive urine ketones. Radiograph of the right hip shows the right femoral neck fracture. Okay, which of the following enzyme is contributing to both the serum and urine laboratory findings? All right, so there's a 72-year-old woman. She was brought to the ED, and she was found awake on the bathroom floor, lying in feces and urine. She fell and injured her right hip. She did not eat or drink anything. She is dehydrated. What's going on? What is this condition called?
Decay.
She's in the fasting in more than 24 hours. In 24 hours, our glycogen storage is already finished. Now her blood glucose is maintained due to gluconeogenesis. And for this one, uh, I
Phosphofructokinase 1.
no phosphoglucose already is functioning for 24 hours, and she's since last 2 days she's lie down on the floor, and now is gluconeogenesis from other sources. After glucose, there is fat. That means I go for lipoprotein lipase, because D is mitochondria is for synthesis of cholesterol. Glycogen A and E is for the glycogenolysis, was already more than 24 hours. And I go for C. I maybe see other one. What the other opinion? I don't know.
I think it's B because your mechanism is all right, but I feel that B is the B is the hormone sensitive lipase uh, is the answer because it also helps to break down the diacyl glycerin free and make glycerol and free fatty acid, and it make helps in ketone.
All right, so is it B or C?
I am with C, and I don't know what others.
So it was B. She was right. It was hormone sensitive lipase. Now, what is basically happening is over here that uh, these are the adipocytes or the fat tissue. Fat tissue cells, triglycerides are converted to glycerol plus fatty acids by HSL, hormone sensitive lipase, and then from there, glycerol and fatty acids are transported to the liver cells. Glycerol is converted to glucose via gluconeogenesis. Fatty acid is converted into ketone bodies. Ketone bodies, we know that they are a source of energy in prolonged starvation, and that is how kind of it goes on. So if you kind of see over here, if you see that, okay, why wasn't it C, right? So lipoprotein lipase is an enzyme. It's found in endothelial cells. Although it is functionally similar to HSL, it works in the bloodstream to form free fatty acid and then transport into adipocytes. All right, so it is only getting transformed into free fatty acids. It's not producing glycerol, which can go on later to produce glucose. All right, so functionally they are similar, but lipoprotein lipase is only producing FFA, which is getting stored into the tissues for energy production. But glucose is a main source of energy for the body, and FFA comes later. So if you kind of see over here that triglycerides get broken down into glycerol and fatty acids, and we need glucose for the survival, because fatty acids and all the other molecules get used up later. First, we need glucose. If glucose is depleted, then only our body resorts to other molecules for energy. If you kind of see over here, again, time of starvation, enzyme provides substrates for hepatic gluconeogenesis and ketone body formation. All right, okay. Next question. Fasting glucose is 90. Plasma glucose levels 2 hours after oral glucose tolerance testing is 185. All right, so which means it's high. Which of the following is the primary mechanism responsible for the patient's abnormal test result? All right, so the patient has cystic fibrosis. He has no concerns. Hyperexpanded chest with equal aeration. Why does the cystic fibrosis patient has an abnormally high OGTT?
Due to the pancreas, I think, is because in cystic fibrosis there is also chronic insufficiency of the pancreas, means pancreatitis, and decrease the uh, release of insulin when there is glucose load. The insulin will not release properly according to that load. Especially postprandial glucose will be high in that patient.
All right, what do other people think?
Yeah, same.
We all agree with A. So it's
Yeah,
A.
decrease insulin production.
All right, yeah. So for cystic fibrosis, we've already talked about cystic fibrosis a lot of times as well. It's, an autosomal recessive disorder caused by mutation delta F508. They ask about that. They also ask about the CFTR. CFTR normally regulates transfer of chloride ions across epithelial cells. If there's a defect in that, it causes thick anticipated secretions, which causes plugging of the ducts, and that is why we're kind of having blockage of the pancreatic ducts as well. There's also increased mucus found in the lungs as well. Sometimes they're also associated with congenital abnormality of, or the congenital absence of vas deferens as well. That is why these people also have infertility issues. Because not only that is happening in terms of pancreas, there are also vitamin A, D, E, K malabsorption going on. So sometimes in a clinical vignette, they can throw, certain vitamin deficiencies, and it can be hinting towards cystic fibrosis because it causes vitamin A, D, E, K deficiency because of pancreatic malabsorption. Why? Because it causes the destruction of the pancreatic cells. If it's causing pancreatic islet cell destruction, as a result, there's a decreased insulin production, and these patients also have diabetes. And so you kind of monitor them with HbA1c. Can anybody tell me, how do you treat cystic fibrosis and how do you diagnose it?
Nitrogen test by the nasal.
It's the sweat test.
Sweat test. Sorry, sweat test. But there is will be increase of
The sweat
sodium and
chloride.
chloride. Yeah.
Yeah.
The sweat
Chloride
chloride.
sweat test.
Yes.
Yeah. What else?
Also genetic testing for mutation.
Okay. What else? Anybody else?
If the infant or child will be more infection in respiratory infection, if clinically thinking, if I think clinically, like more
So simply the
infection would
CFT.
be.
Like
Family
all are
history.
Okay.
those are the signs like infection will lead to elevated sweat chloride level. That is the diagnostic test.
Yeah, so there is this nasal potential difference transmembrane intraepithelial test that you do in cystic fibrosis. Now, sweat test, they don't really ask you on steps. So sweat test is very generic. So what we do is a transmembrane intraepithelial test. It's basically a nasal potential difference test, which is kind of used to assess the function of the CFTR protein. And so that's usually more diagnostic of cystic fibrosis than a sweat test. You can do genetic testing as well, but they'd love to test you on this. Okay, what is the treatment of cystic fibrosis? How do you treat it?
It's actually multifactorial. Like we can do the chest physiotherapy and what else?
Antibiotic, creon, enzyme for pancreas,
Very good.
chest physiotherapy.
Very good. So yeah, you can give certain CFTR modulators. They will not ask you on step one about that. You can give antibiotics, certain mucolytics as well. Guanifacin is one of that. Ivacaftor can also be given. And then there are certain mucolytics, pancreatic enzyme supplements, sometimes bronchodilators as well. You monitor the patients over time because they are, really, really prone to certain infections as well. All right. Good job. Next question. I'm worried that I'm going to get dropped from the team if I don't get myself together. He's sexually active. The patient's father was diagnosed with colon cancer at 64. Which of the following will be the next step to establish, so this is now what I'm hating about step one, that, these next best steps, diagnosis, management, treatment is not a part of step one. Now they're asking that on step one as well. And that is why I asked diagnosis, management, how are you going to treat it? How are you going to diagnose it? from you guys because they are asking you this on step 1 now as well. All right. Okay. So there's 21-year-old man comes to the office because of recent weight loss and fatigue. Coach wants to put on more weight, but I can't seem to do it. It doesn't matter how much I eat, I keep losing weight. I have been really thirsty and drinking lots of water lately too, and it's causing me to use the bathroom frequently during practice. What's happening, guys?
Yes, signs symptoms of hyperglycemia, and yes, before we go for there is history of also now sexual partner also, but we go for first true role of diabetes B, HbA1c.
Yeah, you're right. So what's happening is that in type 1 diabetes mellitus, the patient loses weight or the patient is usually lean. In type 2, you see an obese patient, right? So those are the, two baseline differences. Other is a type 1 usually occurs in younger patients. Type 2 occurs in older patients. Type 1 is usually autoimmune destruction of the pancreatic beta cells. Type 2 is because of the resistance. So again, it presents in the same manner: polydipsia, polyuria, polyphagia, weight loss, blurred vision. An important side effect for diabetes mellitus complication is ketoacidosis, whereas in type 2 you see HHS. So fasting glucose would be greater than 126, HbA1c greater than 6.5, random glucose would be greater than 200. You do OGTT. You also do OGTT in pregnant women to screen them for gestational diabetes mellitus. That is the most specific test. So for a pregnant woman, if they're asking you what is the next best step, you always pick up OGTT because that is more significant in diabetes, in gestational diabetes, and not HbA1c. Okay. So this is a differentiation I want to give you. HbA1c is for general, but for a pregnant woman, you check for OGTT. That's more specific, all right? Because that patient developed diabetes during pregnancy. So that is why this is more, accurate for pregnant women. And if you kind of go down, again, those are the same things we talked about. All right, next question. Urine analysis is positive for ketones. It is determined that the patient's insulin deficiency is causing increased production of gluconeogenic precursors that are subsequently converted glucose in the liver. Which of the following enzymes is most likely to provide these precursor substrates? Okay. So urine is again positive for ketones. She's having diabetes and all of that, which means she's probably having DKA, high anion gap, fruity odor, all of it representative DKA. All right. Okay. Which of the following enzymes is most likely to provide these precursor states? What's happening?
They are asking about the ketogenesis from the Krebs cycle from now, and I think at the end of the, if we see the Krebs cycle from pyruvate, there is enzyme, acyl coenzyme synthesis that helps in formation of the ketones body.
All right. So the answer is?
For me, B. Because acetyl coenzyme is different, ATP citrate lysase, and two other ones, glucose 6-phosphate, for they are in the Krebs cycles for the glucolysis. Glycerol kinase, no, it's also a part of it. I go for B. Let's check the others. So
All right. What else, guys? Everybody agrees with B?
Chandu ẹ̀ kò ní ìtumọ̀ kí lè tètè sùn lálẹ́.
Ah. No. So why is the glycerol? You've done the exact same mistake you did in the previous question. Why do you hate triglycerides so much? What is it with you and triglycerides?
Biochemistry is actually very difficult.
You have certain beef with
It's
triglycerides.
confusing sometimes.
You
It's
don't want to give
confusing.
poor triglycerides a chance to heal the body. So, okay, triglyceride, I understand it's confusing, but just try to get this in your head that triglycerides are the major source of glucose. Not even glucose in itself is a major source of glucose, but triglycerides are a major source of glucose. All right. So triglycerides, biolipase gets broken down into glycerol and fatty acid. There's beta oxidation. That is why there's ketogenesis going on. There's glycerol kinase converting into glycerol 3-phosphate, DHAP, and then there's energy glucose, glycolysis, and gluconeogenesis. So what is basically happening? And then we know that glycerol is produced by the degradation of triglycerides in the adipose tissue. It can be used by the glycerol kinase in the liver and kidney to synthesize glucose during gluconeogenesis. All right. So that is why I'm saying that triglycerides are the major, just for your completion sake or understanding sake, try to remember that triglycerides are always the major source of glucose within our body, not even glucose. Okay, so whenever they give you two options, or what is a major source of glucose, and there are two options, triglycerides and the other is glucose, you pick triglycerides. All right, so not even glucose is a major source of glucose. Triglycerides are a great source of glucose because they not only convert themselves into glycerol, which further goes on to produce glucose, they also break down into fatty acids. And fatty acids we need. Why do we need fatty acids? Because they get converted into ketone bodies, and ketone bodies are are a reserve for our body so that they can help us if we are starved or we haven't eaten for long. So ketones are a major source of a backup plan for the body, right? So not only it is providing active form of energy, it is also providing us a reserved form of energy. And that is why triglycerides are a greater source of glucose or energy to the body, because they're also providing with the present energy and energy needed in the future as well. All right. Is it clear, guys? Clear? Okay.
Yes.
So, all right. Okay. So, glandular tissue approximately 2 centimeter in diameter is palpated under the nipples in the mildly tender palpation. There is no nipple discharge, breast asymmetry, or rash. The patient's breast findings are most likely due to which of the following drug effects? Okay, so there's a 65-year-old man with BPH, comes to the office. He has a history of obstructive urinary symptoms that were unrelieved with tamisulin. All right, a new medication was prescribed at his last visit 8 months ago. Since starting the new medication, the patient has experienced gradual improvement in urinary hesitancy and strength of urinary stream. However, he also has noticed a significant increase in size of his breast. All right, what is an adverse effect of?
Spironolactone. Gynecomastia is caused by spironolactone.
All right, so what is the answer?
D.
D.
Increased peripheral conversion of testosterone to estradiol.
So it's D?
D, yes.
All right, so you should be aware of what drugs are caused gynecomastia. So spironolactone is one of them. Ketoconazole, they love to ask you about ketoconazole, spironolactone, sometimes cimetidine, but not that much. Sometimes about finasteride. So any basically testosterone blocking thing is going to have an opposite increase, right? That already makes sense because all of the hormones are in a level, right? They're kept in a check. If one goes down, the other automatically goes up, not because the other is getting overly produced, but because in relation, I'm sorry. So in relation with the other hormone, it looks greater. All right, because the other is going down, the other automatically looks greater. So that's just the body effect. Again, try to remember spironolactone, ketoconazole, cimetidine as a major source of gynecomastia. Remember, in a young boy, there is no they love to ask you about what is the source of gynecomastia. In a young boy lesser than age of 16, it's always physiological. All right, so you don't do anything about about that. You ask the patient to you reassure the patient, and you tell them that it's going to be okay, because until 16 it's going to be physiological gynecomastia. You can evaluate for Klinefelter after 14 years of age if you feel that not only There's gynecomastia going on. There are other problems with the patient also going on. So after 14, you would probably evaluate for Klinefelter. And until 16, there's always physiological gynecomastia. Obesity is the prime number one cause of, gynecomastia in males. All right. Okay, next question. The patient receives IV fluid boluses and blood transfusions and is taken to the OR for fracture repair and removal of the hematoma. On the first post-op day, laboratory results show high plasma glucose and lactate levels, which of the following is primary contributor to the patient's elevated blood glucose level. So what has happened is there's this 34-year-old man admitted to the hospital after, a head injury and broken femurs after a motor vehicle collision. CT reveals extradural hematoma. Okay, what's happening? We talked about this. What's happening? The patient is in stress.
Stress, cortisol, anabolic hormones.
Is it adrenal crisis?
What's happening?
D1, increase hepatic glucose production.
Adrenaline due to stress, epinephrine. D.
D in stress of glucolysis genes, in stress it will increase the glucose in the blood, hyperglycemia in perioperative time area.
Gluconeogenesis, hepatic.
Yes, perioperative most of the time this one, because there is none mentioned which IV fluid. If there was mentioned dextrose or other one, that maybe versus expect that it's maybe due to IV fluid. But patient is with major trauma and major surgery. He's in stress and look like yes, the D, hepatic glucose production.
Yeah, so I said stress hyperglycemia, right? The patient is in stress. We talked about this yesterday as well. Whenever you have motor vehicle accident patient, burns patient, hospitalized patients, sometimes, increases. Why? Because of increase in cortisol. So if you see over here, cortisol is increased. Cortisol is a stress hormone. It's released from the pituitary in response to stress. What it does is it increases the levels of glucose because our body is in like a fight and flight mode, and we need extra glucose to heal the injured tissues. So it's a body's physiological response to stress. And there's also pro-inflammatory cytokines. Another thing what I want to mention is that you don't if the glucose is excessively high, then you start insulin. But when you start insulin, you need to monitor the potassium levels as well. So you do both of them at the same time, because we know that insulin causes hypokalemia. So if we don't want the potassium to be lowered too much, because if the potassium is lowered too much, then we can have a lot of problems, right? So we don't want that. It can cause a lot of heart arrhythmias as well. So what we do is that we monitor the patient for glucose, and if the glucose is excessively high, then we start the patient on insulin, and along with that we start the patient on potassium if the potassium levels fall because of insulin. Otherwise, we don't really stress about the stress hyperglycemia, because when the condition is normalized, it can go back. But sometimes these periods can go on later in their life and develop diabetes mellitus. They have an increased chance of developing diabetes mellitus in the future as well. All right. Okay. Next question. Further testing shows that his plasma lipoprotein lipase activity measured after IV heparin administration is substantially lower than normal. If his condition remains untreated, the patient is most likely to develop which of the following features. All right. Okay. So there is a 6-year-old boy, and he's had a traumatic fall from his bicycle. Physical examination shows a large laceration over his left leg that is irrigated and closed with sutures. When he's receiving care, a routine blood draw shows milky plasma. All right, very interesting. Milky plasma, creamy appearing, supernatant upon standing. What is this?
This triglycerides are chylomicrons, yes, blood sample plasma, there is some specific layer, this yellowish, milky layer.
It's type 1 in acute pancreatitis.
Pancreatitis, yes, that's cause.
Is the one.
Yeah. So we discussed about them yesterday. I'm not going to go over through that, but familial chylomicronemia syndrome can present in a deficiency of a lipoprotein lipase. And if you remember correctly yesterday, I was like that you need to remember this because they asked about this, the protein defects, elevated lipoproteins, and the major manifestation. What I want you to remember that xanthomas are going to be there in all three of them, 1, 2A, and 3. But the location varies from type, all right? So like tendon xanthomas will be in type 2A, eruptive, which means all over the body is going to be in type 1, and palmar xanthomas are going to be in type 3. So that's usually a giveaway or a beautiful differentiation between what type of hyperproteinemia it can be, right? All right, okay. Next question. What is this? What's going on?
It's xanthelasma.
Xanthelasma, yes, I lead. Yeah.
Xanthelasmas. All right, okay. 42-year-old woman. All right, okay. Which of the following is the best? See, again, they're asking best next step. This is a step 2 question. I don't know why they're asking step 1. They made it difficult for you guys. All right, what do we do?
Serum
Serum
lipid and blood sugar
and blood glucose level.
B.
B.
B. Yes, B.
I clearly remember this was on my step 2 Q bank. I don't know why they're giving you this. Okay. Xanthelasmas is a type of xanthoma. We talked about that. It's because of the accumulation of macrophages. It contains cholesterol and triglycerides because there's cholesterol. You see it has a yellowish tinge to it sometimes. And are generally associated with primary secondary hyperlipidemia, and that is why we usually monitor lipids and blood glucose level. Remember, lipids and glucose go hand in hand together. Whenever there's glucose, we are going to monitor the lipids as well, and whenever there's lipids, we are always going to measure the glucose as well because they both go hand in hand together. If you have read about coronary artery diseases as well, you might have seen that in the management plans, we do everything. So we do a lipid profile, we check for glucose, we check for every risk factor that can be associated with a CAD. But blood glucose and lipids, they go hand in hand together. They are the primary contributors of xanthelasmas. All right. Okay. Calcium is 10. Glucose is 698. Interesting. Glucose is 698. 20-year-old woman. Nausea, tachycardia, dry mucous membrane. Okay. Is it an increased anion gap or not?
No.
No, because sodium is low. This due to the high blood glucose. Chloride 93 also is a decrease. Bicarb 12 decrease.
Yes.
Bicarb decrease. Yes.
Yes.
Yeah. Bicarb is this.
All right. What's
But
going on? Is it
blood glucose is
DKA
very too much.
It's
Hyperosmolar.
actually DKA.
Is it DKA or HHS?
Hyperosmolar look like.
DKA.
Because in DKA there is blood sugar not with this level. This 600 plus is hyperosmolar.
Yeah, you're right. So first of all, increased anion gap metabolic acidosis is very distinctive of a DKA. The other thing is the glucose level. So if it's usually less than 500 or 450, then that's DKA. If it is greater than that, most likely they're referring to HHS. There is this thing written in your first aid. I don't know if you've read it, but they say that HHS is in the late 800s or 700s. That is actually misinformation. It need not to be in that high range to be categorized as an HHS. It can be greater than 500 and it can still be categorized as an HHS. All right. If you kind of go down. Okay, what's going to happen to the potassium?
Intercellular decrease and intercellular increase. C.
Both decrease because when is shifting of the potassium from cell, it will come to the extracellular, and from extracellular it will was excrete to the urine. That will, both side will be decreased. I will go for A.
A.
C. I mean C. C.
A or C, guys? What's a major consensus?
Total potassium, from my opinion, total potassium decrease.
So your opinion
it will
for
be
C.
It's A, I think.
C. It's
Oh,
C.
C.
The why was it? Oh, interesting. So it was DK. It wasn't HHS. Interesting. Now, why is it
Patient A,
DKA? It's interesting.
Because ma'am, patient 20 years old, that's
I
why.
have it.
one
Young patient.
Young patient, maybe type 1 diabetes.
No.
Because,
Oh, the patient had high anion gap. You guys missed
yes.
it. That's why I asked you to calculate it. I didn't calculate it for myself. Sodium minus fluoride plus bicarbonate. If you do that, 93 plus 12. Let
Yes,
me let.
we told ma'am that's the
Yeah, we
high
told
gap
I
because the
gap.
bicorb is low. That's why, if we
Oh,
uh,
you guys said it was.
minus, yeah,
Yeah.
Oh, you said it was high. I misheard it. I'm
yes.
sorry. I
Mm.
misheard it. I apologize. I didn't calculate it. But yeah, so
But
DKA is very
mm,
of high anion gap. They have high anion gap. So again, high anion gap is, don't go to the glucose levels, because if it's lesser than 500, most likely DK, greater than that HHS. But what we usually distinct on is the anion gap metabolic acidosis. You should have a high anion gap metabolic acidosis for DKA. If the anion gap is normal, most likely they're referring to HHS, irrespective of the glucose levels. Okay. This can also be, variable in between both of them. In DKA and HHS, both can have the same age as well. So it really doesn't give much of a difference. What is the patient undergoing? What gives us a difference is this DKA, is the anion gap. All right. So we know that intracellular potassium stores are going to be depleted, and overall it's going to be increased, right? So this is why it's also called as masked hypokalemia, because when we measure the potassium stores, it looks normal, but in actually the potassium is low, and that is why we give the patient potassium along with the treatment over here. All right, so what is the treatment for DKA? Anybody?
IV insulin.
IV fluid. I first IV
first
fluid
IV
to
fluid,
hydrate the patient.
then
Then
Yes, then
insulin,
insulin. Then
and
if check the blood sugar early, then if there is blood glucose less than 200, start the glucose also.
All right, okay. All right, anybody else?
And treat the cause also. First one. Most of if there is infection or abscess, anything else also.
So first step is we do fluid resuscitation, all right, because the patient is
IV
already
fluid, yes.
dehydrated, so we have to restore the fluids. You can give any IV fluid. There's no specific hinge to it. You can give 0.9% normal saline. You can also give lactated ringers. You can give both of them. It's okay. After that, you can start with insulin therapy. The third thing I want you to focus on is electrolyte replacement. All right. So electrolytes, like I said, potassium is severely low over here. So you have to give potassium chloride in a patient who is severely hypokalemic. Otherwise, it's going to cause a lot of arrhythmias. You can sometimes also correct magnesium, because if there is air, if you've given potassium, even after correcting the potassium doesn't go up, then it's because you have low magnesium, right? So that is, if there's a resistance in the potassium going up, even if you've given potassium, that's because of low magnesium. So you have to first correct the magnesium, and then the potassium will automatically get corrected. So sometimes that can also happen. You can give magnesium to those patients as well. You have to monitor these patients. Again, you have to also do supportive care to these patients. The other thing I want you to consider is about bicarbonate. Bicarbonate, sometimes people try to replace them and say, oh, it's a little bit lower, try to replace it, but it's not usually necessary. The other thing is that cerebral edema can be also a serious complication of a DKA. It can occur both in children and adolescents as well. And that is why I said that DKA is not, the age is not as much of a differentiating pointer, because we have seen cases of DKA in older patients, and similarly HHS patients who were younger. So, that cannot be a great differentiation point. All right, so
Yes,
we
ma'am.
talked.
This bicarbonate, I think no more recommended until unless this
Yeah,
pH is
you're right.
less than
That's
7,
why I said that.
6.9 due to
Yeah,
paradoxical acidosis.
you're right. So that is why I said that we don't usually give bicarbonate. Some people say, oh, bicarbonate is low, but we don't generally do that. But yeah, it's probably for the same reason we don't do that. Okay. Next question. Bedside finger stick glucose level is 35. Okay, very low. The patient is given infusion of glucose, which rapidly improves their metal status. Okay, episodes of hypoglycemia due to increased results of an endogenous hormone. Okay, the hormonal imbalance is most likely causing the patient's symptoms by which of the following conversions. All right. So she's having repetitive hypoglycemia. All right. Blood pressure, okay. Pulse is a little erratic. Respirations are a little high. She's been sweating. What's happening? Why is she having repeated bouts of hypoglycemia? Where is the enzyme having problem with? Yeah. Anybody?
I think, ma'am, C.
Fructose 1,6 bisphosphatase.
All right. Let's see.
Fructose.
Hmm. Yeah, you're right. Again, the patient has developed hypoglycemia because of excess insulin. So the first thing when the patient comes to us for repetitive hypoglycemia and the patient is already on insulin, the first thing we ask them is the teach back method. We ask them to teach us how they're using insulin because sometimes patients aren't aware of using insulin in the right manner, in the right dosage, at the right time. They don't know how to do that. And they've been doing it wrong. And that is why they're using excess insulin. And that is why they're having repetitive hypoglycemia. So that is one thing we do whenever the patient comes to us. It can be another cause. It can be an insulinoma, or it can be, because of a secretagogue as well, or, any counter-regulatory hormone deficiencies. So there are a lot of causes to it. But the first thing we always think of is, oh, the patient is taking a lot of insulin. So we know that phosphofructokinase, it catalyzes the rate-limiting step in glycolysis, and the most potent stimulator of PFK1 is fructose 2,6-bisphosphate. Again, it's a biochemistry-oriented question. If I kind of zoom it to you, you will see that this is a fructose 6-phosphate that's converting into fructose 2,6-bisphosphate by these enzymes. This is phosphofructokinase 2. Then so after here, over here, it's getting converted to phosphofructokinase 1. Enzyme is converting this fructose 1,6-bisphosphate. Again, I always hated biochemistry. I still don't understand it to this day. But yeah, you have to memorize it. There's no other way around it. All right. Next question. Last question for today. Okay. So during a recent episode, the patient's blood glucose level was 32. Okay. As measured by her husband's home glucose meter, medical history includes major depression and IBS. Laboratory studies performed during the next episode of symptoms for the following results. So glucose is 35. Insulin is 18, so it's high. C-peptide is 4.01. All right. Which of the following is cause the patient's symptoms? It's very easy question.
Insulin.
Sulfonylurea use.
It's sulfonylurea use.
As there is a low C peptide. No, C
No, it's
peptide is okay. Yes,
High,
yeah, C
high.
peptide is okay.
high, and
That means
insulin is
it's
also high.
endogenous insulin,
Yeah.
and that's secreted by yes,
Sulfonylurea.
D, sulfonylurea. Yeah.
Yeah.
It's sulfonylurea.
Yeah. So good job. How do we know what if the C-peptide wasn't high?
That means it's the insulin secreted by the pancreas. Is if the C peptide low, that means there is some exogenous use of insulin.
Mm-hmm.
And in case of insuloma or insulin secreted by the pancreas, there is C peptide also.
Again, Whipple's triad is something I want you to be familiar about. That Whipple's triad is a triad of low blood glucose level, symptoms consistent with hypoglycemia like tremor, diaphoresis, confusion, and the relief of hypoglycemic symptoms when you drink a sugary drink or when the blood glucose is corrected. So this is a Whipple triad. Now, evaluation of hypoglycemia can be because of a lot of things. It can be because of exogenous insulin, that you're taking a lot of insulin. It can be because of oral hypoglycemic agents that include secretagogues, such as sulfonylureas, and it can be because of any insulinoma as well. Now, the way that you differentiate is that C-peptide is low in exogenous insulin because, again, the insulin that we administer does not have C-peptide in that. It can only be released from the pancreas at the same time. So insulin production along with C-peptide can, that's only through the pancreas if it produces pancreas, if it gets produced by the pancreas. But it's not in the injection, and that is why exogenous insulin, you have C-peptide that's low. For oral hypoglycemic and insulinomas, the serum insulin that's both increased, that's both same. C-peptide is also elevated. But how do you differentiate between sulfonylureas and an insulinoma? So you do it by hypoglycemic drug assay, and when you do that and you find out if it's positive, it's for oral hypoglycemic agents, and if it is negative, then it can be an insulinoma as well. So that is why it's really, really high yield if you understand this table. They love to test you on that. And yeah, good job, guys. We're done for today. Are there any questions that you guys have?
Can I ask you something? Can I ask you something?
Yeah, sure. Go ahead.
The beta blockers also cause hypoglycemia, or they hide the tachycardia, and that for this reason the patient cannot feel the tachycardia, cannot feel the hypoglycemia? Which is the effect according with the hypoglycemia in the beta blockers such as propranolol?
So beta blockers mask hypoglycemia, right? And why is that? Can anybody tell me? Why?
Because it's blocked the
They
sympathetic
block the
system, yes, sympathetic action, and in hypoglycemia, in people triad, there is activation of the sympathetic system, autonomic sympathetic system. If already blocked by beta blocker, there will be no tachycardia, no sweating. It will mask all the symptoms of hypoglycemia.
So what's happening is that in beta blockers, the reason they're masking hypoglycemia, like he said, such as a rapid heartbeat or tremor, it is because they block the effects of epinephrine and norepinephrine, and which are normal, hormones that play a role in the body's response to low blood sugar, right? So we know that adrenaline is a stress hormone, norepinephrine is a stress hormone. So whenever there is low blood sugar, these are regulated, right? These hormones come into action and kind of elevate the level of sugar in the body. So when you give beta blockers, these hormones get stunted down, and when they get stunted down, then we cannot be able to tell if it's actually hypoglycemia going on or not, right? So that is why, because we know that these hormones, they cause a rise in the heart rate, increased sweating, and there are other symptoms that help people recognize hypoglycemia as well. When you block these hormones, beta blockers can blunt or kind of eliminate these warning signs, and that is why we say that beta blockers mask hypoglycemia. Yeah.
So don't cause directly hypoglycemia such as sulfonylureas. They only block the sympathetic response when the patient have tachycardia or these symptoms due to the hypoglycemia.
Yeah.
Right? Okay. Thank you.
Yeah, you're right. So sweating is unaffected, but it can, increase sweating. It can be the only noticeable sign of hypoglycemia in some individuals taking beta blockers. In some individuals, we see increased sweating, but they may not completely block sweating in a lot of individuals. So yeah, you're right. Okay.
Can I ask you another thing? It's not for so we did a question of gynecomastia, and you say that in all the patients under 16, usually the gynecomastia can be normal. I mean, it's no a red flag to keep it.
No red flag. Yeah.
Okay. So always that the patient will be more young between than 16 is no a red flag. That is I mean, 10,
Yeah, so
9, 8.
no. What I meant was that if a boy who's 15 years old, he comes to the clinic and he says, I've got no other problems, but I've got, I feel that my breasts have become enlarged, right? What do? Will you run an entire genetic test on him? Will you what will you do? So if he's got no other problems, and if there's an increase in the breast mass tissue and he's less than 16 years of age, then that's physiological. We don't treat it. All right. So as long as the patient's fine, we don't treat it. On USMLE, what I want you to remember, if the patient starts developing symptoms, then we start to do anything about it. Otherwise, they want the patient untouched. We don't touch the patient unless they are symptomatic, right? So until 16 years of age, they're totally fine. But if they're having a lot of other issues along with gynecomastia, then we can think of Klinefelters, and then we can do genetic testing or any other testing that's involved, hormonal profile as well, to kind of eliminate Klinefelter syndrome or any other cause of gynecomastia. So that's what we do.
Thank you so much.
All right. Okay. Anything else? No?
Thank you, ma'am. Thank you.
All right. Okay. Yeah, that's right, Dr. Jamil Muhammad. Hormones spur in teenage, and that's exactly what is happening. There's growth going on throughout the entire body, and that is why we usually don't pay attention to that in a younger boy. But yeah, we'll talk to you tomorrow. Good luck, guys. Happy learning. I'll see you tomorrow.